Our lower respiratory system emphasizes shifts from conditioning air to conducting it efficiently, as well as facilitating gas exchange. The lower respiratory tract must balance rigidity to maintain patency with flexibility to accommodate pressure changes during breathing. There are two main zones in the lower respiratory system or lower respiratory tract. There is the conducting zone and the respiratory zone. The conducting zone functions purely as a passageway and air conditioning system, while the respiratory zone contains the structures that are responsible for gas exchange. This distinction is important clinically, as diseases like asthma primarily affect the conducting zone, while emphysema, which is a type of COPD, chronic obstructive pulmonary disease, affects the respiratory zone. Prior to getting to any of those major structures, though, we have our kind of next structure along the pathway down, which is our larynx or voice box. The larynx has three critical functions: maintaining an open airway, directing air and food appropriately, and producing sound. Structurally, it's composed primarily of hyaline cartilage, which provides rigidity while allowing some flexibility. The epiglottis, made of elastic cartilage, plays a crucial protective role during swallowing, preventing aspiration. The larynx will extend from C3 through 6 and attaches superiorly to the hyoid bone. The thyroid cartilage forms the prominent anterior shield, while the cricoid cartilage provides the only complete ring of cartilage in an airway, a key landmark for airway management. The paired arytenoid cartilages are essential for vocal cord movement and voice modulation. The vocal cords consist of vestibular folds, or false cords, and vocal folds, or true cords. The glottis refers to the space between the true vocal cords. During quiet breathing, the glottis, which we can see represented here and here, remains open, while phonation requires precise adduction and tensioning of the cords. Injury to the recurrent laryngeal nerve can impair this function, leading to hoarseness or airway compromise. Speech as a whole is produced by the intermittent release of expired air through the glottis. Pitch is determined by vocal cord length and tension, while loudness depends on airflow force. Resonance is shaped by the pharynx, oral cavity, nasal cavity, and sinuses. Fine motor control of the tongue and lips transforms sound into intelligible speech. The larynx can also function as a sphincter, most notably during our Valsalva maneuver, where we're bearing down like you're having a bowel movement. Closure of the glottis allows for an increase in intra-abdominal pressure, stabilizing the trunk or facilitating defecation. Clinically, this mechanism also explains why breath holding can transiently increase blood pressure and intracranial pressure. Histologically, the larynx demonstrates a transition in epithelial type. Superior portions are lined with stratified squamous epithelium to resist abrasion, while inferior areas inferior to the vocal folds, shift to a pseudostratified ciliated columnar epithelium to help with mucociliary clearance. This pattern reinforces the concept that epithelial structure directly reflects functional demand. One component to consider is the cough reflex. This is a vital protective mechanism designed to rapidly clear the airway. Irritants stimulate vagal afferent fibers in the airway epithelium, which relay signals to the cough center in the medulla, which is in our brainstem, the medulla oblongata. In response, a coordinated motor pattern is initiated: deep inspiration, closure of the glottis, contraction of expiratory muscles, and then forceful expulsion of air once the glottis opens. Clinically, impairment of this reflex, such as in neuromuscular diseases or central nervous system injury, can greatly increase risk of aspiration. This is kind of the end of our upper portion. Even though we're in our first section of our lower respiratory tract, this is kind of ends the structures that are separate from what we consider kind of true lungs or our true respiratory components, the trachea down below. Next, we're going to shift deeper into the lower respiratory tract, and we'll start moving through those anatomical structures and discuss some of their functions.